Hello and welcome to the GP Pharmacy Club pod. I'm Adam. Today we're tackling the NICE Guideline NG28, which covers the management of type 2 diabetes in adults and was last updated in June 2022. This is a rich guideline covering everything from first-line therapy to managing complications like neuropathy and kidney disease. Whether you're a GP, clinical pharmacist, or diabetes nurse, these updates are key to delivering care that's safe, effective, and tailored. Let's begin. Georgia, what can you tell us about the overall thrust of the guideline?
Thanks, Adam. First off, individualized care is the golden thread running through the guidance. NICE puts individualization front and center. That means assessing comorbidities and polypharmacy risks, reviewing therapy at every contact, considering quality of life and patient values, especially with multimorbidity or reduced life expectancy. Remember to reassess needs regularly and be willing to deprescribe if benefits aren't clear. This includes accounting for disabilities like visual impairment in how we deliver care.
That makes a lot of sense. It's calling for a partnership between the clinician and the patient. That leads us to the second pillar within the guidance: education. It's important to note that we are not just talking about handing the patient a few leaflets. Structured education is a must, at diagnosis and reinforced annually. NICE outlines what good education looks like. It should be delivered by trained educators who understand adult learning theory. It should also be regularly audited for outcomes and quality. Interestingly, group education is preferred, but alternatives must be equal in standard for those unable or unwilling to join groups. In undertaking all this, it is important to ensure that cultural, cognitive, and linguistic needs are met. It feels as if I shouldn't have to say this, but the education must also be evidence-based, with clear aims and theory-driven curricula. In an age where there is a lot of misinformation on the internet, health professionals must ensure that the information they provide is of a high standard and inspires patient confidence. This is about empowering self-management, not ticking boxes.
I couldn't agree more. We then need to consider diet and weight management. Dietary advice must come from someone with proper nutritional expertise, and it must be ongoing. Tailor it culturally and practically. In terms of diet, the basics include high fiber, low glycemic index carbs, low-fat dairy, oily fish, and reduced saturated or trans fats. Weight loss targets are typically 5 to 10%, but even modest loss helps. We need to integrate dietary advice with physical activity and broader lifestyle planning. It is also noteworthy that NICE continues to discourage diabetes-specific specialist foods such as diabetic sweets and similar products. They don't add value to the management of type 2 diabetes and may mislead patients in other ways. The ideal is for ongoing support to be available from trained nutrition professionals, hence we need to be making greater use of those Tier 3 referrals to dietetics and weight management.
Let's move on to a consideration of cardiovascular risk and antiplatelet therapy. This is straightforward. Firstly, do not offer aspirin or clopidogrel for primary prevention unless there's established cardiovascular disease. Secondly, use the broader NICE guidance on lipid management and QR risk when assessing risk. This reflects updated evidence on bleeding risk outweighing benefit in lower risk populations. It also means that you would assess a diabetic patient the same way as other population groups in primary CVD prevention. What can you tell us about the role of blood glucose management and HbA1c targets, Georgia?
Well, Adam, this is where that golden thread that we mentioned earlier comes in handy: individualized care. We now aim for individualized HbA1c targets. For patients on lifestyle therapy or drugs without hypo risk, we generally aim for an HbA1c of 48 millimole per mole, which is equivalent to 6.5% for those using the older convention. For patients on insulin, sulfonylureas, or drugs associated with a hypo risk, we generally aim for an HbA1c of 53 millimole per mole, or 7% in old money. However, as stated before in relation to individualized care, NICE recommends that we consider relaxing the target HbA1c level on a case-by-case basis and in discussion with the patient, particular in frailty, and in the elderly under certain conditions. Examples include where sticking to the ideal targets is unlikely to achieve longer-term risk reduction benefits. For example, people with a reduced life expectancy, or where tight blood glucose control would put them at high risk if they developed hypoglycemia. For example, If they are at risk of falling, they have impaired awareness of hypoglycemia, or they drive or operate machinery as part of their job. It also includes situations where intensive management would not be appropriate, for example, if they have significant comorbidities. In terms of frequency of measurement, HbA1c should be measured every 3 to 6 months until stable, then every 6 months. On the other hand, capillary blood glucose self-monitoring is not routinely recommended in type 2 diabetes. NICE recommends that we reserve it for insulin users, people such as drivers on drugs with hypo risks, during corticosteroid use or an acute illness. Adam, what can you tell us about the role of continuous glucose monitoring, CGM?
There is a big shift here. We should offer intermittently scanned continuous glucose monitoring, is CGM, also referred to as flash monitoring, to insulin users if they have recurrent or severe hypoglycemia, impaired awareness, cognitive impairment, or would otherwise have to self-monitor 8 or more times daily. We should also offer this to patients who would otherwise need help from a care worker or healthcare professional to monitor their blood glucose. On the other hand, we should consider real-time continuous glucose monitoring, RTCGM, as an alternative to ICGM for adults with insulin-treated type 2 diabetes if it is available for the same or lower cost. Importantly, CGM doesn't eliminate the need for capillary blood glucose measurements completely. This is because patients will need to use capillary blood glucose measurements to check the accuracy of their CGM device, or they might need capillary blood glucose monitoring as a backup, for example, when their blood glucose levels are changing quickly, or if the device stops working. CGM should be delivered with education and specialist support. It remains optional, and we should adopt the principles of shared decision-making with the patient around adopting it. As in other aspects of healthcare, it is essential to monitor usage, review annually, and address inequalities in access.
Great. That takes us to pharmacological therapy. We'll discuss the individual drugs in detail in another post. Here's the quick summary. First line is still standard release metformin, unless contraindicated. If CVD or heart failure is present, or CRISC is high, add an SGLT2 inhibitor with proven cardiovascular benefit. Start metformin slowly to mitigate GI side effects. Consider modified release forms if needed. If metformin is not tolerated, consider SGLT2 inhibitors, DPP4 inhibitors, sulfonylureas, or pioglitazone, based on patient profile. If the HbA1c rises to 58 millimole per mole, 7.5%, or higher despite monotherapy, reinforce adherence, then step up to dual or triple therapy. We are going to cover GLP-1 mimetics in a separate post, but it's just worth pointing out that if they are used, they should be continued only if there is a reduction in HbA1c of 11 millimole per mole or greater, and a 3% or greater body weight loss in 6 months. Do you want to quickly go over insulin therapy?
Sure. We know that for some patients living with type 2 diabetes, we may need to move on to insulin therapy. Insulin therapy should start with a structured plan. Full details are in the guidance, but keep in mind dose titration, self-monitoring, hypoglycemia management, and DVLA guidance. We should also continue to offer metformin for people without contraindications or intolerance. Review the continued need for other blood glucose lowering therapies. Neutral protamine, Hagedorn, NPH, insulin is the default. Offer NPH insulin injected once or twice daily according to need. Consider starting both NPH and short-acting insulin, particularly if the person's HbA1c is 75 millimole per mole, 9.0% or higher. This may be administered either separately or as a pre-mixed, biphasic human insulin preparation. Consider Detamir or Glargine if the daily injection burden or hypoglycemia risk justifies it. Also review if bolus or premixed insulin is needed for postprandial control. The guidelines makes it clear that NICE backs the use of biosimilars where cost-effective and safe in agreement with the patient.
Before we conclude, let's review how we manage the risk of complications. NICE makes the following recommendations. Firstly, for periodontitis, remind patients of the link with glycemic control at the annual review. Prompt dental care improves outcomes. Secondly, suspect gastroparesis in patients with erratic control or vomiting. Treatment options include erythromycin, metoclopramide, or domperidone. However, note that the use of erythromycin here is off-label, and you need to consider cardiac risks and interactions when using domperidone. Neuropathy is another common complication. Watch for GI symptoms, bladder dysfunction, and hypo-unawareness. In CKD, use ACE inhibitors or ARBs if the ACR is greater than 3. This should be titrated to the highest licensed dose that the patient can tolerate. Add SGLT2s if ACR is greater than 30, or consider if the ACR is between 3 and 30. For male patients, there remains the risk of erectile dysfunction. Screen patients annually and consider a phosphodiesterase 5 inhibitor as first line. Finally, consider eye health. Refer patients for screening at diagnosis. Encourage patients to attend eye screening and explain that it will help them to keep their eyes healthy and help to prevent problems with their vision. Explain that the screening service is effective at identifying problems so that they can be treated early. The following are grounds for emergency review by an ophthalmologist: sudden loss of vision, rubeosis iridis, pre-retinal or vitreous hemorrhage, and retinal detachment.
Thanks, Georgia. So, what are the final takeaways? NICE NG28 reiterates a shift from glycemic tunnel vision to holistic, patient-centered, risk-adjusted care. As clinicians, we're in a prime position to guide patients safely through complex drug regimens, ensure continuity of monitoring, and champion structured education. It's about more than glucose metrics. We're managing people, not numbers. Let's aim for clarity, safety, and collaboration in every decision. For full guidance, head to nice.org.uk/guidance/NG28. And as always, remember, guidelines inform, but people decide. If you found this helpful, please share it with a colleague. Thanks for tuning in to the GP Pharmacy Club podcast. From Georgia and me, see you next time.